when they're coming in the hospital, and they're, even with receiving the antispasmodic medication, it really does not help much. They're on several seizure medications as well, muscle relaxants and things like that. They even be on some pain medication as well. So it's a very, for a child to be diagnosed with anything, and difficult to diagnose. I mean, I don't think, in utero can't really identify, that, from an ultrasound or things like that. It does not show us, that the child is going to be born with that cerebral palsy. So,
do you have to wait till like 3 months before you can petition?
Approximately. A physician, depending on, pediatrician should be present, when the newborn is born, and do a detailed assessment, and probably then a detailed assessment. He probably can identify with something. Then again, he may just want to say, I just feel, want to monitor closely. But maybe, I might not want to give parents heads up, but, I'm seeing some things that are not, really normal for your, newborn baby. And so we'll continue to monitor, but, and some could really just probably show, something so quickly, so easily, yeah. Because you can see in this picture here with the hypotonia, we were just trying to do, and you can just see, lack of any tonicity there. Very, very floppy baby. So, as the baby is still to continue to grow and things like that, I don't know how nutritionally, I'm trying to feed the newborn baby. I'm not sure how nutritionally they will respond, Could they possibly have a poor suck and not, things like that.
So diagnosis consists of comparing instead of growth chart and growth skills.
It could be possibly, but newborn, that's going to be kind of difficult. But, as they continue to grow, you could, see what percentile that they fall in. But then you're going to be looking at what the normal newborn or whatever 1, 2, 3 months should be doing. And then, because when they're coming for their well baby checkups, that's when you really probably be able to identify. Mom might even tell you it's just something, I don't know. She can't describe it or what, but she knows something is just not right, Maybe it takes her 30 minutes to an hour just to bottle feed the baby. I don't know, things like that. Because at that time, they're not doing much. So how can we really identify? Because they're sleeping and eating, things like that.
So what can a nurse even do for this child besides giving them medicine?
You're gonna, give their medication as ordered by the physician, and be very, very empathetic with the parents and be there for them. Maybe assist with the feeding sometimes, maybe give mom a break. She can leave and you're gonna feed the baby for lunch. It's the best. And just prevent from aspiration and, how she should probably hold the child and things like that, And sometimes they do kind of have a lot of drooling and saliva and stuff, because they may have to suction a little bit and things like that, So, that's a good question. Follow the orders, I don't see them because they're on such strong medication for seizure activity that I don't really see them seeing that being a problem there. And then they don't really gain weight so quickly. They're really needing to gain weight. So you don't see where, the seizure medication is not, working for them. But the spasmodic, I don't really, that's just, you can't really sometimes do a good assessment. You do as much as you can. May have to come back later. So, it's just that, that kind of patient.
There she is.
Yeah.
Waiting.
I think I talked about this one time briefly. Anencephaly, absence of both the cerebral hemispheres and of the overlying skull, actually experienced this, and they wanted to, the mother continued on with the process of labor and everything, and delivered, and they only lived for a couple of days. Maybe I think this baby maybe lived 3 days, but they roomed in on the pediatric floor. That was something that they chose to do, so that was very emotional, for everyone, and heartfelt for the family. But I think that closure there for them to do that was good for them, good grieving process for them, mom and dad, and even some of the grandparents were there as well. They had a nice ceremony and all that. So you just never know, Have I seen anencephaly a lot? No, but I've seen it a few times. So. Wow. Yeah. So the question was, and I'm not quite sure either on, with the ultrasound and, looking at the development and things like that, I think that they just, still wanted to continue with the pregnancy and continue to delivery and things like that. So Down syndrome, what goes on with that? What's actually happening?
Extra chromosomes.
Extra chromosome, greater risk for mothers with greater 35. Right. Usually diagnosed with clinical signs, if not diagnosed in utero. And we already know about the amnio, right? Amniocentesis can identify those things too. Sometimes, women who become pregnant after or, are the age of 35, they just want to know, if there's, and some, it doesn't mean that they're not going to continue their, pregnancy and all of that. It does not mean that, but they just, want to have some idea and be prepared and things like that. Down syndromes are functional, right? They live a long period of time. Some are working, right? In different facilities. I'm sure you maybe have seen some, they do well. They don't drive or anything like that. The parents might still bring them, but, they dress themselves and they feed themselves and, communicate and, you can't tell, it's a little bit difference, but that's okay, so it's great to see that, And then some of them go to some of our different schools, that, take care of those. Then we have Augusta Evans is the name of one of our schools in Mobile, and I'm sure there are several here, but they can just be there all day. And so that kind of helps too, I think they graduate when they're like age 21 or something like that, or maybe just however long it takes, And then some of them begin working, if they can. Some of them can't tolerate, just probably being around people a long periods of time and trying to communicate. Some of them get emotionally upset, over different things. So, you just have to, let the parents make that decision and evaluate them and things like that. Whether it's good for them to do that, but it's good for the parents. The parents, that helps a whole lot, Monday through Friday. That the buses, I think a lot of them pick them up and they bring them home, and so that still gives, because just think, if this was your child and you're having to deal with, different things, then you have other children too, and that's a lot. Can be financially expensive, everybody don't have, proper insurances to take care of everything, but it's a lot of resources. And so we have to tap into the resources. And so that's great from our pediatrician and our social worker and, things like that. A lot of Catholic services, they have a lot of different things where they help do different things for, children. We all love our children, so we try to make, things, there for them. So we have to inquire. So what do they have? They have the upward and outward slant of the eyes, the small nose, depressed nasal bridge, hyperflexibility and muscle weakness. Might see the tongue protruding, at birth a little bit. Sometimes they're born with heart defects, septal defects, atrial septal defect, or ventral septal defect. Not everybody, but sometimes. And then they have the wide space in the plantar crease between the big and the second toe. So these are prominent features that you all may want to make sure that you're aware of or have some idea of for the Down syndrome baby. And understanding the pathophysiology, So, Down syndrome will help you. So you want to rule out cardiac anomalies with evaluative echocardiograms. Assess their respiratory status because they have hypotonia muscle tone. And then there's an inability to cough, expectorate, decreased drainage of mucus due to their nasal development, how the septum lies and all of that. So we have to do some bulb suctioning. And then it makes them more prone to respiratory infections as well. Assess the ability for adequate nutritional intake, the palate, sucking a bottle. Gastric motility is pretty much slowed down due to the hypotonia as well. So high fiber, increased fluids. Promote attachment with the family. They're very, very flaccid extremities. So swaddle the infant, the blanket, so they can secure them and hold them well. And early intervention with speech and hearing delays helps with cognitive functioning, thinking and thought processes. And because you still can hear some, with the speech, a little bit of hypernasality, a little bit sometimes. So priority actions, we pretty much already identified that. Cardiac respiratory nutrition in the infant with history of issues should be addressed with the assessment of a child.
So if this child is hospitalized, go home and be on EKG monitoring.
We probably do an EKG on them. Yeah, they wouldn't have to be on an EKG monitor, but they will have already assessed the heart. Cardiologist has already seen the baby, probably even at birth. The pediatrician has already made consults, and they may even come to the hospital before they discharge as a newborn. And may not have ordered much at that time, and probably won't do that at the hospital, but probably follow up with the cardiologist and other things will already be in place. So that's just a list of myths, if you want to just read that about, what can occur, and maybe correct the myths, that people would say. So here, trauma-related injuries to birth injuries, pretty much already identified by the cephalhematoma. Cranial nerves in the face may be affected, causing the facial drooping or the itosis, which may be transient, kind of like a lazy eye, pretty much. And so, it's pretty much already covered meconium, but we'll get on in just a minute. Some of the goals thought to improve the neurological outcomes of a newborn with a hypoxic disorder, maintain their blood glucose level, blood pressure, controlling the seizures, and minimizing cerebral edema. And so that's what we've already gone over, and what we're trying to do with the meningitis, with the seizures, encephalitis, but we give the steroids, the osmotic diuretic with the Rye syndrome and all. So meconium aspiration, probably won't say much on that. I pretty much know. Should not be tested on that again. Should have been tested already. Visual disorders, strabismus, misalignment of the eyes. Do good visual exams on the children, babies. Probably identified as they get a little bit older, the strabismus and the growth and development and things like that. Everybody I'm sure you've seen strabismus on someone. Misalignment of the eyes. May just be one eye that, there's, not total positioning or the focus, and they're deviated more to the left than looking forward. The right eye is okay. So we need to make sure that they get well baby checkups and our pediatricians assess properly, and then we make referrals and things like that. May have to have surgery. Said that uncorrected strabismus leads to amblyopia. So that's a reduced physical acuity in the eye results when one eye does not receive enough stimulation. And so then that will be permanent. So we have to try to correct that visual disorder, that strabismus. Somebody might say cross-eyed, things like that. You may have heard those words, because untreated strabismus leads to amblyopia. Conjunctivitis, everybody know what that is? Pink eye. Is it contagious?
Yes.
Okay. Bacterial. Sometimes people have allergic conjunctivitis. So I have always had problems with my eyes, and I have allergic conjunctivitis. But when I worked in the hospital, they didn't know, So I did go home one day, because the sclera was a little bit red. But my sclera gets reddened, but I don't have vaginal. I don't have any discharge. Any yellowish drainage, from my eye or anything like that. So I had to bring a report, a doctor's, report showing that, it's more allergy, clears up with hardly nothing. I do nothing, and put a little Visine or something like that in it. But these individuals need what? Medicated
Eye drops.
Eye drops, right? To treat it. Very, very contagious. Generally, after what period of time can they return back to school?
24 hours.
About 24 hours, so make sure that, we feel as though mom is compliant. I'm concerned about the child that comes back and you still see thick yellow drainage, have they seen the doctor? So we need to have the excuse. Probably may need to have the medication, right? Because they probably need it. You put it in, a drop or two every 4 hours throughout the day. And so the school nurse can do that, easily. Because they need to continue to receive it. But the rule of thumb is, after 24 hours, they are non-contagious, but. So hearing disorders, kind of pretty much talked about the otitis externa, infection of the outer ear canal, the acute otitis media, chronic otitis media. What makes it chronic is just it's reoccurring, right? acute is sudden, it just happened at one time, maybe we treated it and things like that.
Awesome.
And then it continues to, they've had it over 2 to 3 times, and it makes it more
Put it down.
chronic
Slow
there.
down.
Or we call it the swimmer's ear, otitis externa. Brought about water that remains, there's a residual after swimming, creating a moist environment where bacteria can grow. Putting fingers, cotton balls, or other objects in the ear also can lead to swimmer's ear by damaging the thin layer of the skin lining your inner ear. So yeah, definitely gonna need antibiotics, antifungal medication, maybe on steroids, reduce inflammation. So, that's probably what you would see for that cerebral palsy client, right? Dysphagia diet, then puree dysphagia diet, or thicken it, sometimes with honey, so they can swallow the food properly. It just depends. They would be on a high calorie, high protein diet. But everything probably would be pureed most of the time. I don't even think soft food. It just depends on the extent of that client that has cerebral palsy. If they can even tolerate soft food, it would have to be pureed most of the time. So anticonvulsives, what do you give those for?
Seizures,
Corticosteroids,
everything.
everything. Osmotic diuretics. What do we say particularly? For what disease process? Raynaud syndrome, skeletal muscle relaxants,
Cerebral palsy.
ophthalmic otic antibiotics,
For eye infection, ear infection,
acetaminophen.
everything.
Thank you.
You said the osmotic solution was for the
Cerebral palsy.
rye.
I'm sorry. The
Rye.
Rye syndrome. Okay, give me about 2 minutes, and we're moving to what?
Integument.
Integument is next. I don't know what. Do we need to talk about integument? Right. So who's coming to the board? I got some things on the board.
We were talking about
Well, it looks like the 5 key points already on there. So 5 key points. All right, who's coming to the board to tell us a little bit about integument, and we're gonna go with what they're saying, and we're gonna keep it moving. 5, I think it's 5 people need to come on the right. Tell us about the diagnosing, what actually happens. I guess I'll move this up. Okay, maybe I need to. What actually happens? Treatment, signs and symptoms, isolation.
everything?
No, I just want you to write one.
Oh, okay.
Just one. 4 more people can come. Don't let the same people that come all the time.
We need rock, paper, scissors, guys. Come on.
3 more people, please.
I'll take Lyser and Potato.
Oh, it's only 4, I'm sorry. Well, the ones who has ringworms, they got a lot. Oh, you're right. One more person.
I did not listen to you, so I'm sorry. I was just asking which one.
We're just gonna be right there.
We need one more student, please. One more volunteer. You just have to, huh? But nobody else wants to get up.
That's ringworm, you said?
Where? But you all need to learn these terminologies here, attending your capital sport, curious, and all that.
You got smoothies, Vitiated,
You got ringworm.
If there's medication,
She's still on the inside.
he's filling it in already.
She's doing some for you.
Oh, I didn't see you walk up here. You can take a Potato. I'll take it. Yeah, I'll take it.
If there's medication, you need to name it. Okay, about 3 minutes.
Yeah, that means everything. Like you have to wear like everything.
Really moisturizing.
It's 10:38, and I'm not doing What? What's going on? I'm hungry. She won't let me wait. Wait till.
By doing what, cooking?
She's at Walmart. She said, we told her about that. She said we can't charge her. We can't because we didn't have any food trucks. That's not a good excuse. I have a great excuse. I can literally go to Walmart after your really good. Now we're back to 3 or 4. That's your son. I'm talking like I started now. How long does it take to do your There's no ration.
Here's how this goes. If you get her like a sandwich or like a nice sandwich, she's eating it, so you don't hear it. Okay? And then you can get everything that you need in peace. And then when she gets done, she's having to take it out.
I just think so between now and then. Ooh, the hot and spicy.
I'm excited to get peanut butter. You like barbecue? You need a cow whole if you do. With a side of pig. Dessert, chicken for dessert. Grab it.
Some cholesterol.
Does this look weird to you?
No.
It looks too rounded.
No. You didn't put that back right.
You got that?
Stop! Why does everyone harass me? You do harass me. Never. Never harass me. You always harass me. I love that stuff. Give me some. You just drop that all over your leg. I don't know, I can tell. Oh, it was your ring. I thought it was a hand sanitizer. I was like, that would literally just like, I really thought it was. The hand sanitizer was very good, and I just. What does it doing what? He's like,
Okay.
Take a picture of you.
This is a close order.
Breathe in, breathe out.
That's right. That's all you do. Come on, Miss Pearson.
Shut up. You're taking pictures.
For that.
Shake your face.
If they're lucky. If they're lucky.
Hold on, what's that say?
What? A peppermint?
All right, y'all want to talk about those? Well, we get to it. So INTEGUMENT, how we're assessing the skin.
Go again.
Every shift, right? What are we looking for? How we're assessing the skin. Okay. Any of those abnormalities, right? We're educating, right? How to prevent a lot of childhood skin problems. Many of them are contagious, right? And so they need to be treated before they return back to school. About your kind of like no time frames when they can return and things like that. One second. So let's try to finish this before 11. I don't know what important factors: age, epidermis is loosely bound, layers separate easily. May see atopic dermatitis on the infants. May have some birthmark malformations. More than half of the dermatologic problems in children are forms of dermatitis. School-age children, we pretty much see ringworms, acne, those kind of things there.
Can you put the screen down?
Oh, I'm sorry. And
She
sorry.
hates that machine.
All right, pretty much said that. Age is important. Epidermis is loosely bound. All of that. School age, you see ringworms and acne. They say that atopic dermatitis. Sometimes it's just due to not changing the diaper right frequently and keeping the and hygienic measures as well. What do they complain about? Itching is one of the number one. And even the toddlers, school age, preschoolers are scratching and everything can become infected. We've seen that with chicken pox, and they develop cellulitis and have to be admitted to the hospital. Then they're on intravenous acyclovir and other medications. So that's the main thing. We just try our best to give them some type of antipyretic medication. Maybe giving Benadryl at home, elixir, maybe 3 times a day or just as needed, or to help with that itching and things like that. May have some pain or other sensations. We observe the infant and small child's behavior. Then we observe the signs and symptoms of infection. We may have to do cultures on things. Some may be fluid-filled vesicles. Some may be pustules. It just depends. We need to describe it, how it looks when the child has been admitted to the hospital if they have to. You rarely see somebody come in with scabies. Impetigo can lead to what? Cellulitis as well. They can claw there, scratch, and it become very, very infected where they have to be admitted as well. A doctor will do some cultures, some skin scrapings, and may even have to do a biopsy in some severe cases. Main thing, we want to prevent complications, provide relief. So we may give some medication for discomfort, the itching, eliminate the factors of dermatitis that's possibly causing, the problem for the infants. Avoid heat. It aggravates most conditions. And we may clean the areas with normal saline. So pruritus, how can we treat it? Cool baths, wet compresses. Definitely may have to mitten the infant's hands, a toddler, even preschooler maybe. Cut the nails. Topical corticosteroid may be used if indicated, and we may give the Benadryl. Most of the time you see the infants, children getting the Benadryl as opposed to the Atarax. That's a bit stronger, but you possibly could. Works very well if it's given appropriately, So, infectious and inflammatory. More than half of the dermatological problems in children are forms of dermatitis. This implies a sequence of inflammatory changes in the skin that are grossly or microscopically similar, but diverse in course and causation. Acute responses produce intracellular and intercellular edema, the formation of intradermal vesicles, and an initial infiltration of inflammatory cells into the epidermis. The location and the manner of these reactions produce the lesions characteristics of each disorder. The changes are usually reversible, and the skin ordinarily recovers without blemish unless complicating factors such as ulceration from the primary irritant, if there's scratching, an infection or introduced or underlying vascular disease develops. All right, malaria. What do we know about malaria? Don't see it much, right? At all. Impetigo, not gonna say anything really there about malaria. Impetigo, who wants to speak on it? Impetigo, they just wrote something on the board. See it often. Who wrote it? Oh, you did. Tell us about that kind of loudly, Lou.
Well, it's bacterial. They have like the reddest macule type, I guess, lesions, and they erupt. They are moist and they erode. You can catch it by direct contact, and they use for treatment oral or topical antibiotics.
What's the name of that
You can use
antibiotic?
a triple antibiotic ointment for the topical one. And
What else can they use for it? What is
Bactroban.
Mucin is the #1 medication. At one point in time, they did do, the triple, but the Bactroban is awesome, right? I don't know if anybody has ever had to use it or whatever.
Yeah.
It's very expensive, and it kind of like helps treat. Well, it does treat, but prophylactically, anything that can lead to MRSA development. Yeah, Bactroban or Mucin. Very, very expensive. But she said, or antibiotic, penicillin, they may have to take. And sometimes if they're having to be admitted, right, due to cellulitis, everything's gotten really, really just affected, it's within the system, they're receiving IV vancomycin. And it may heal, it may have some scarring based on how much the child has been scratching and things like that. And so when it's honey-colored crusted, you'll see where the exudate dries to a honey-colored crust, it is still infectious, right? Honey-colored crust is infectious. That's a good NCLEX question. Saying it several times. Students have said it several times. Just want you to be able to identify and know.
So hand washing is a big deal with this patient.
Hand wash it. Might want to cut the nails, mention the hands, giving the antipyretic, right? That's gonna help a whole lot because the medication has to take a while, before it really clears up. So you definitely need to be making sure you're taking care of the itching, right?
Bactroban. Well, said I got 2
The
minutes.
parasitic disorders. What are we talking about there?
Head lice.
Okay.
Yay.
Who wrote about lice?
I did. That's contact isolation. The adult lives 48 hours away from the host. Lifespan of an average female is about a month. Eggs hatch in 10 days, mature in 2 weeks, meaning they can have more babies and more babies. Itching, white nits in the hair, possible bite marks. Never actually seen that, but I guess it's okay. It's easily spread. They cannot jump, but they can spread from clothing to clothing, couch,
Very good.
furniture, car, things like
They do
that.
not jump and they do not fly, but from person to person and personal items.
Items, yeah. So do not share things. Always tell the kids don't wear somebody else's hat, jacket, any of that crap. Use a hairbrush.
How do we treat it?
Treatment, we got rid. You have to pick out all the nits. Mayonnaise works really well. If you don't have money to go buy that expensive rid stuff, you can suffocate them with mayonnaise and then pick all the nits out. Yeah.
Okay, when do we use the nicks? The 1% nicks, the pedicular when do we use that?
I guess if you get them in the pubic area.
Okay, remove the nick cases on infants and children, and the permethrin 1% kills the adult lice and nicks. Takes about 7 to 10 days to ensure that they're pretty much cured. You do daily removal and comb the hair completely, and you do daily removal with a metal knit comb or a flea comb. They do not jump or fly from person to personal items. Caution, as she stated, about the sharing of combs, hair ointments, hats, caps, scarves, and coats. School-age children are generally affected more so. The knit eggs hatch in 7 to 10 days and cause the itching, crawling insect saliva on the skin, maybe in the occipital area behind the ears and the nape of the neck. They're kind of grayish tan in color. They're small, they have no wings, and they are visible to the naked eye.
Oh, yes, they are.
They are attached to the hair shaft. That's the definitive diagnosis. They kind of like some people distinguish them. They'll say that they're dandruff. but they are attached to the hair
Yeah,
shaft.
you have to pull them off the hair shaft. And a preventative is tea tree oil. You can put tea tree oil in the shampoo and keep it, it'll keep them away. And then, of course, not washing your hair every single day. Dirtier hair they don't like.
Yeah. What kind of isolation would they be on? In the hospital?
Contact.
Contact, and sometimes, like if that's a new admission that's being, no one is really admitted for life.
Right, unless it's just
They're
extremely
coming in
bad
for
and they're sick.
another underlying
Right.
disease process, and then we see. And so sometimes in the process of you as the nurse having to remove the nits and things like that, we do cover the head, put, gown, put the gown, all of that, but they are on contact precautions, just as your extra precaution there.
Is impetigo, is that contact as well?
Impetigo is contact isolation as well. Yeah. If you come in contact with the honey crusted, they're contagious at that time. MRSA, what do we know about MRSA?
It's staph resistant.
We have nothing resistant staphylococcus aureus inside our body, right? So whenever there is an open cavity, it lives there. So open wounds, that's why you see MRSA living. And so sometimes people that get insect bites and things like that, they scratch, and what do you have? MRSA usually, a lot of times. Usually they'll tell you that the pimple or the vesicle is very, very painful at site, and what does it have? A greenish discharge. But it's very, very painful at site, and so he does a culture and automatically it's MRSA. Sometimes if you've had MRSA, in a wound, whatever, insect bite, whatever, it's kind of repetitive. You have to make sure that they're really treated. So sometimes they'll give you Bactrim, right? And sometimes they'll give you oral vancomycin. Yeah. Could be reoccurring.
Or IV vancomycin.
Fungal infections. Who have fungal infections? Okay. What are our fungal infections that our children experience?
Ringworms are probably the biggest, besides for like parts or yeast.
So this is the word for ringworm, tinea, and this tells me what part of the body that it affects. So you need to know these. Tinea capitis is what?
The head.
Tinea corporis,
Body.
tinea curis,
Hand? No?
jock itch, okay, and tinea pedis. Okay. All right, so tinea is the ring that identifies and that identifies the location. All right, so tell us more about it.
It's usually it's a dry, round, patchy. It almost looks like psoriasis. It can be red and white, black looking like. When you treat it with antifungal, we wash everything. It is contagious. So if you rub it up on somebody.
Right, very contagious.
It can be passed between people and people, and animal and people. So that's why they say like don't snug up on your dog.
Right.
Cats mainly.
So, with the, go ahead.
You don't have to go, you technically don't have to go to a doctor for it. You can just buy the stuff over the counter. But
If you actually know that that's
if you
exactly.
actually, if you
Oh, you can see that. It's a round ringworm.
Yeah.
it's one or two things.
And it spreads very easily.
It does spread
Yes.
very easily, so you actually have to monitor
Yeah.
and make sure that it is getting smaller and
Right, the
drier.
diameter, yeah. Okay, very good. So capitis, as she stated, that's the head, can be from person to person. We can treat them with oral medication though. You can give them the oral ricofulvin. Very nasty tasting medication, the children say that it is. Sometimes when children just keep getting them repetitively, the physician may put them on the oral ricofulvin. Not necessarily trying to put an ointment in the scalp. It might be a little difficult to, make sure that that's working right. But on the body, we might use a topical ointment, an antifungal, Lotrimin, things like that. That can be passed from pets to humans. The jock itch, topical, pretty much, antifungal, and the
A lot of athletes foot.
with the pedis, you may use a cream, and some may have the ricofulvin as well. The other antifungal we talked about was the candidiasis, right? The oral thrush, and we also may see diaperdermatitis as well. And we said that we'll use the nystatin or the mycostatin, and so we can use the mycostatin ointment for the diaper rash and the mycostatin oral medication for the oral thrush as well, right? So just going through the contact dermatitis, may have the topical steroid may be required for 2 weeks. Eliminate 3 factors: the acidity, so the wetness. If we relieve eliminate the wetness, we relieve it from the acidity, right, of the urine, and then the fecal irritants. So it's just about keeping your child, properly changed, hygiene, changing the diapers frequently. Maybe you want to use cloth diapers at home, and the Pampers, the plastic, and things like that. You relieve it, but a lot of people don't want to do the work of the cloth diapers, but it prevents a lot of that dermatitis from developing. Eczema, you may see that as well. Wear on the elbows, inside the crevice of the arm, back of the knees. You can see things there. Face. See it a lot with our asthmatics for some reason. Most asthmatics, if you know of an asthmatic, they have eczema too. Probably the steroid cream that we use, triamcinolone, most of the time. Cream works a whole lot in taking care of it. But they itch. That can get infected easily, it can spread, and they can be hospitalized. I do know of one case that was hospitalized for the eczema because she was just itching so much that it became infected and thawing and things like that. Malaria, I won't say much there. A little prickly heat, sweat rash on the baby. Vesicles erupt, occurs due to increased intent hyperpyrexia. Impetigo, kind of like covered that. I don't think there's much to say there. The honey crusted. Say that again?
So the heat rash doesn't need to be rubbed?
The heat rash doesn't need to be rubbed.
Did you say that?
No, I said sweat rash. It's prickly heat, sweat rash. Itching is common. We say with the impetigo, itching is common with most of these. She's already identified, oral and topical. There's the Bactroban. They can be anywhere, when it's child scratches and things like that. See one there, honey crusted, so it still hasn't healed. Still hasn't healed there when you see that. Assess for increased infection, fever, tachycardia, chills, and malaise. And then you got to know what type of isolation contact, right? Cover drainage with sterile dressing. So if it's draining, you never send them to school like that. So we said about 7 to 10 days. And everybody's different. Everybody's different. The number. Parasitic disorders, lice. Already right there. By medication, read your book because it is some other medication that we've described as well that may not be on there. More updated. Scabies. Who did scabies? All right.
Bed bugs.
Caused by mite.
She lays 2 to 3 eggs every day for a month. And basically you get the itching when the mites come
Extreme
out of the
itching.
bed bugs. Extreme itching. And they
That's
bite you
hilarious.
and you feed and then they go back into the blankets and stuff. You treat it with permethrin and you treat everyone in the family because it's close contact. And I guess
What's the treatment for it?
permethrin.
Okay, the permethrin. Okay. So those steroid creams that we may be using, it's good. How do we apply a steroid cream?
And only to the affected area,
Yeah.
Very good. Why?
because it's steroids, and you don't want it to go any other place.
It can become systemic. Be a very thin layer, right? Yeah, thin layer applied. I think she covered that. Anybody got any questions about scabies? MRSA? Kind of isolation. Contact.
Yeah, contact.
Just remember though, I'm concerned, when a person has it in their areas, it's not an open wound at that area at that time. I just feel like sometimes we should have on a mask, Sometimes we put it in the back of the band on Q-tips inside the areas as well. Treat it like that, but that's just my concern,
Well, isn't it?
But if the patient is not on
That's normally
isolation,
where they
I don't
check
try,
it.
I
You can see if you
rather
got it.
not. I won't go
They have it in
there.
their throat or in their sputum, they'll put them on chocolate.
Yeah, I thought
I've
it was
never
wrong.
seen it where,
Yeah.
I've taken care of many
It
of
happens
them.
all the time.
Put the Bactroban in the areas and they're still just on contact because that is the isolation for it. No matter where it is, it's contact. Because if they have an open wound, the only way for you to is if you're changing that dressing. Yeah. is contact. So, you have to, and CDC is very, very, they stress that a lot. They want you to know, make sure that you're implementing, because that is the transmission of anything, yeah. So, all right, hand washing. Showing the pictures of the ringworm. Say much there. Burns, what do we need to know about burns? How do we prevent them?
Putting things away that don't need to be
Touch the
out.
water before you put your baby in the tub.
Pretty serious, right? When are they generally hospitalized? For electrical burns, loss of consciousness, ECG changes on the ECG monitor. When there's probably about 10% of the body, total body surface area has been burned. Need to monitor an extremity. Looking at the airway, right? NPO probably. Nutrition is a problem. Nutrition is important. Increased calories, protein, very good. Maybe on tube feedings, could be on continuous tube feedings, maybe on supplemental. Pain is a major problem. So we're medicating them. Do conscious sedation for them when we do the dressing changes. That's not done on the floor. And first degree maybe, the second, third, fourth, fentanyl and propofol. And so checking a pre-albumin pretty much every morning to make sure that their protein level is well, right? And that helps with the proper healing, tissue healing, right? So high calorie. And you'll see them get extra food. The doctors, you have doctors that take care of burn patients only, and they really know, that's what they specialize in. And so they're very, very concerned about that pre-albumin level. If the child is receiving the proper diet, they have a calorie count sheet on the door, and things like that, because they know all of that helps with the tissue healing. Even though they're, cleaning the wound and the burn areas properly and all that, still the other things need to take place too. Proper nutrition, supplemental. Sometimes they get Pediasure with every meal, can of Pediasure, things like that. Weigh them daily weight, strict intake and output. So all of that. So infant skin is thin, so injury will be deeper. Minor burns, stop the burning process, cool water, but no ice. There's some with some hot scald burns, then cover with a clean cloth. Major burns are immediate threat for shock and airway. Less than age 3, kind of said there's a higher mortality rate due to the immaturity of everything. So after stabilization, I mean the airway and all of that, ruling out shock, preventing that, and the management of the wound can be done in several different ways based on the degree of the burns. Maybe debridement, 3rd, 4th degree burns. Then they have to have skin grafts possibly after that, so they're still in the hospital a little bit longer. Take the skin from a healthy area, and then you got to make sure that area is healing where they've done the skin graft properly. And so it's pretty serious. Can be in the hospital 3 to 6 months depending on the degree of the burn, or longer. I think we talked about the acute and emergent phase, pretty much there. Monitoring the vital signs, intravenous fluids, respiratory assessment, check the pulse every 1 hour. Teaching, cross-contamination. And then we're in the management, and now we're rehabilitating, preventing any type of wound infection. That's very, very important with our burn clients. Sometimes we are doing strict isolation and caring for them, depending on the degree of the burns. Is that we definitely want to protect them and keep them from getting anything, because that's going to really take them downhill and even more of a problem. If they develop any type of wound infection, anything can lead to bacteremia, getting in the bloodstream, and then you're just really, really with major, major problems there, and increasing cost and expense and things like that, and time for the parents. Everybody can't take off from work, forever, but somebody needs to be there with the child. Covered here. Topical medications, 8%. I stress that one more so than any of the other concentration. Okay, that's what we use mostly. covers. And then the permethrin and the Hicks, which you both for the tuberculosis and the scabies. See how do you apply those, kind of like what on that. So you take a 10-minute break. Thanks for letting me finish that.